So we have the next another practical and very important topic, that is once daily insulin clinical practice, a patient case perspective. For this we have Dr. Narayanan NK. He is a senior consultant endocrinologist and diabetes specialist at Apollo Hospitals, Greens Road, Chennai. Sir has two MRCPs, one in internal medicine and another in diabetology and endocrinology. He also has authored a book titled that Lecture Notes for Cambridge Medical Students. He wrote on diabetes and metabolism chapter in that book. He has also been a part of formulating the guidelines for East Angelina regional guidelines for management of pituitary tumors, and he has also won the Best Abstract Award for his work on non-invasive lateralization technique in primary hyperaldosteronism. Sir seems to be a great academician, and sir, over to you, sir.
Thanks, Dr. Kumravil, for the kind invite. Thank you, Chairperson, for the kind introduction. Dr. Manikandan's talk has really given a very nice prelude as to how the newer generation insulins have changed our practices. Fortunately, over a century since the discovery of the insulin, we have gone through phases of using the animal insulins to the human insulins to the analog insulins. Now we call this as a second generation analog insulins. So each and every transition in the phase of changing from one type of insulin to another type of insulin has increased the patient perspective, patient satisfaction, as well as given us a big armamentarium of different types of insulins that we can use to control diabetes. As Dr. Manikandan was alluding to, different strengths of insulin, 100 IU to 200 to 300, 500 has made the changes as to how people take the insulin. Also, the different pharmacokinetic properties of the insulin. As you were saying, human insulin have to be taken like half an hour before your food. The analog insulins can be taken just before your food or just after your food. In the same way, the basal insulins have also changed. When we talk about basal insulins, we know the early generation basal insulins were the NPH, which in a type 1 diabetes have to be administered at least twice a day because the duration of action is around 10 to 12 hours, which is slightly difficult for the patients who are already taking 3 times short-acting insulin and the basal insulin on top of that, which changed once the glargine U100 was introduced because it was more like a 24-hour insulin. So people were able to take once a day insulin for their basal requirement, both in type 1 as well as in type 2. And as we started using more and more of glargine U100, we also started noticing that it is not actually a full 24-hour insulin, although much better than the NPH that we were using previously. So one step better than the NPH was the glargine U100. Now we talk about the second generation basal insulins, which are far more better because the pharmacokinetics allow you to use this insulin as a truly once a day insulin. I'm saying truly once a day because the glargine U100, we all know that in many individuals it may last for 24 hours, but there are a good proportion of individuals where you administer the glargine U100, the effect lasts for about 16 to 20 hours. There is a tail end effect where the effect of the basal insulin wears off, therefore the sugar starts increasing. Let's say they take the insulin at 10 p.m., glargine U100, the effect of that wears by 4 p.m. the next evening, therefore a tail end increase in sugars is something which we had to struggle with. Also, it was not a truly basal insulin which has completely got a flat profile. Although we call it as a basal insulin, it did have a slight peak at some point in time. So there were some variations in the basal profile of the insulin that we were using. So these were the restrictions which we had, or the limitations which we had with the first generation basal insulins. Now, my talk is focusing on once daily insulin in clinical perspective, both talking about a basal as well as the ease of administering a bolus as well as a rapid acting as well as a basal together. So a typical patient, a 50-year-old male, 11 years type 2 duration, HbA1c of 8.8, obese, with a BMI of 27, his fasting sugar is 188, postprandial is 218, and he's got all the metabolic syndrome parameters, which I'm not going to go through in detail. He was irregular with his physical activity, no case of hypertension and hyperlipidemia. Not an atypical patient who we see on a day-to-day basis. He's already on metformin 1 gram twice a day, empagliflozin 25 milligram once a day, an injectable GLP-1 analog which is now available now, which was liraglutide. Despite which his sugars were not under control, he's got a hectic life. He fears insulin initiation, which will affect his work life due to the risk of hypoglycemia. Again, not an uncommon scenario in most of our patients. He travels often and unsure about taking insulin at a fixed time of the day. So what would be the insulin that we will use in this patient? Looking at the guidelines have also changed. We remember a decade ago we used to read about metformin being the first agent, then the sulfonylurea, then we talk about which should be the third agent. No more of these guidelines nowadays. Any drug can be used, almost any drug can be used as the first agent depending on the patient in front of you and the pharmacokinetics of the drug that is which is available in your area. It could be an SGLT2 inhibitor, it could be a GLP receptor agonist, it could be an insulin. So depending on the patient profile, the type of first agent that you're going to use is also going to differ. As well with this, the guidelines have also moved on. The ADA 2024 guideline says when you're thinking about, after using all the oral agents, which is not controlling their dose, when you're thinking about using an injectable agent, now they're talking about using GLP-1 receptor agonist or the more recent dual agonist, which will be launched later this year in India. The dual G and GLP-1 receptor, as you know, GIP, gastric inhibitory polypeptide, and GLP-1 receptor agonist together form the incretin pathway. The incretins are a very important component in controlling diabetes, both endogenous or when you're administering as an exogenous agent. Both ways, it's a very important component of managing type 2 diabetes. So either using a GLP-1 receptor agonist or a GIP GLP-1 receptor dual agonist is what is recommended as the first injectable. Again, you need to take into consideration the cost and other factors, whether the patient can afford it. If they can afford, if the cost equation is taken out here, then that could be the first agent which could be used. After which, then you are talking about insulin, which could be a basal insulin. Again, the guidelines differ. Most of the international guidelines talk about using basal insulin as the first insulin when we are talking about initiating insulin in a given patient. In the Indian context, it might be slightly different. Our own RSSDA guidelines also recommend that when the fasting as well as the postprandial sugars are very high, then you would even consider using a mixed insulin given twice a day as your first choice rather than initiating a basal insulin. So really depends on the patient who is right in front of you. Assuming you got a patient who is like this, where the fasting is not very high, the postprandial is slightly elevated, HbA1c high, then basal insulin could be the next choice. In which case, whether you want to use a first generation insulin or a second generation. I think we already touched upon this when we talked about the limitations of the first generation insulin, where the half-life is about half a day. Some of the patients, we have seen that they've been using glargine U100 as twice a day insulin because once a day was not able to cover the entire 24-hour time duration. Therefore, the ultra long-acting basal insulin analogs, glargine U300 as well as degludec, which are both available in India, have changed the landscape of using basal insulin in our patients. The first generation insulin, the limitation not truly once daily. They have higher variability. I said there is a slight peak. There has to be a fixed time dosing, giving an interval of only half an hour before and after. They are not truly peakless. Sometimes they did develop a nocturnal hypoglycemia, definitely much lesser than the NPH which we used to use previously. Among the second generation insulin, which are only two, glargine U300 or degludec, both are very good insulins. I think both the companies have done pharmacokinetic marvel by introducing these U300 and the degludec, both of which have been invented very, very passionately sitting through the lab work, and each has got its own strengths and limitations. When we talk about both these insulins, I'm sure clinically both of these are equally efficacious in controlling the glycemia, but there are subtle variations between these two insulins. Degludec, when we talk about the strengths of this, there is a lower within-day variability compared to the glargine U300. We can see from the diagram here, left-hand panel being degludec and the right-hand panel being the glargine U300. Also, the degludec shows a lower day-to-day variability compared to glargine U300. And this is something which we have all experienced clinically. People who have used both the insulins, we will know that the insulin glargine U300, the dose requirement is slightly more, about 15 to 20% more than the insulin requirement for degludec. It is the nature of the insulin in which it acts, the pharmacokinetic properties of the insulin. But at that particular given dose for glargine U300 and degludec, I don't think there is clinically any big difference in terms of the efficacy. The efficacy is almost the same, only the dose requirement is slightly more for glargine U300. Flexibility wise, degludec has got a lot more flexibility because the nature in which it acts, the glargine U300 has to be administered within 3 hours before and after. Let's say somebody takes U300 today at 9 p.m. they can take it the next day anywhere between 6 p.m. to 12 midnight. So that 3 hour window is the flexibility range with Glargine U300 offers, whereas Degludec offers a range between 8 to 40 hours. That means there has to be a minimum interval of 8 hours between one Degludec and the next Degludec injection. There could be a maximum gap of up to 40 hours before they take the injection. Literally talking about this, somebody takes the insulin Degludec tonight, tomorrow they can take it either in the morning, afternoon or night, depending on their work nature. So this is very useful for people who have got a highly flexible life. Let's say they are out in the field for most period of the day tomorrow. They don't have to think about where I need to come back exactly at the same time to take my insulin exactly at the same time. This has to be, this can be taken at different time points in the same day, still giving the same effect without causing hypoglycemia. It's because of the elimination half-life of the insulin. Let's say they take 30 units of insulin today, the next day 50% of it gets eliminated, that is 15 units. The next day they take 30 units, the remaining is 30 plus the previous day's 15, 45 units, half of that gets eliminated the next day. So there is no cumulative effect of this insulin causing hypoglycemia because the elimination half-life is dependent on the amount of active insulin that is there already there in the body. So Degludec definitely has got its advantages in terms of its convenience. It can be administered any time of the day, an inter-injection period of about 8 to 40 hours, no relationship to the meal. It doesn't have to be before or after meal, and they don't have to, it doesn't depend on the meal portions either. So it's approved in pregnancy, pediatrics, adults, elderly, renal and hepatic impairment, and as Dr. Manikandan was telling, it's the approval process for pregnancy has changed. It's not as such an FDA approval. It goes through the categories when we talk about usage of insulin in pregnancy. How do we initiate insulin Degludec? It is administered either alone or in combination with OADs, GLP-1. Recommended starting dose is about 10 units per day. Again, differs from individual to individual. And obviously depends on the daily requirement. You titrate it every third day to achieve the fasting control. From switching from one insulin to another insulin, especially when you are switching from a human insulin to an analog insulin, doesn't matter which analog it is, you would expect a reduction in dose requirement. So approximately you do at least a 20% dose reduction whenever you're switching from a human insulin to an analog insulin, else you will see that they land up with a hypoglycemia very soon. So Degludec is a flat peakless activity profile, minimizing the risk of hypoglycemia. It has got a long duration of action, allowing dosing flexibility and a minimal variability from day to day. The second patient is a 53-year-old businessman, 7 years of type 2, much worse control here, HbA1c of 9.2%. Again, a typical overweight individual, BMI of 25. The fasting is much higher compared to the first individual. This is 206 fasting and 288. Both fasting and postprandial are more than 200. His LDL cholesterol is 138. Again, a person with metabolic syndrome, is a non-smoker, doesn't exercise much, has got hypertension for 12 years and hyperlipidemia. He is on metformin 1 gram twice a day, sulfonylurea 2 milligrams, and that is glimepiride 2 milligram twice a day, and dapagliflozin 10 milligram once a day. Again, the hesitancy to use insulin, he believes that taking insulin will be difficult with his hectic daily routine. The fear of hypoglycemia is always there. It's always there in the patient as well as sometimes in ourselves when we initiate any treatment for the patient, whether it's sulfonylurea or insulin. One thing which we do not want our patient to come back to us with a severe hypoglycemia. They may very well change the physician very quickly. Even if they have a slightly poor control, they don't bother. But if they have a severe hypoglycemia after initiating a treatment, then immediately they switch over to a different physician. Uncontrolled hyperglycemia, having an erratic diet pattern, and travels often and unsure, taking insulin at a fixed time of the day. Now, the need for good postprandial plasma glucose control along with the fasting glucose control cannot be overemphasized. We heard from the first two talks that the amount of carbohydrate, amount of calorie intake, all determines how far the glycemic excursion is going to be there. It may be that the amount of carbohydrate determines the immediate glycemic excursion. As Dr. Arun was very nicely telling about the calorie restriction, it's only outside it is carbohydrate, protein or fat. Once it goes inside, if you recall our basic biochemistry, there is something called an intermediary metabolism, right? The ATP generation can happen from your carbs, from your protein, from your fat, depending on what is available inside the body. The body has got the capacity to interconvert one to another. So it doesn't matter whether you take the carbohydrate or too much of protein or too much of fat, Eventually, it gets stored when the calorie is there in excess. It's the immediate effect of the carbohydrate which shows up when we check the blood glucose value that matters. And the Indian context, when there is too much of carbohydrate intake, the glycemic excursion is so significant that the postprandial plasma glucose contributes to the high levels of HbA1c that we see. Therefore, controlling the fasting, the postprandial plasma glucose, both together is important. We all know that fasting glycemia can be controlled with the basal. The postprandial plasma glucose, you need a bolus insulin. Hitherto, we had to administer two types of insulin. We had to administer a basal insulin at night time, and let's say the post-breakfast sugar is high or post-lunch sugar is high, then you will have to administer another rapid-acting or a short-acting insulin separately before the breakfast or before the lunchtime. That means they have to take two insulins together. Now, the insulin co-formulation that we have now, which was not available previously, as we know, glargine is an insulin which is slightly acidic. And that's the reason why they couldn't combine a rapid-acting or a short-acting insulin along with the glargine, because they cannot coexist with each other. Most of the insulins have got a neutral pH, or pH around 7, whereas the glargine is an insulin that is slightly in an acidic. So you cannot combine these two things together, which is another pharmacokinetic marvel that the newer generation insulins have given, where they could combine a basal insulin as well as a rapid insulin together, what we call as a insulin co-formulation. So this is distinctly different to the mixed insulin that we have. Mixed insulin, you have an intermediate and a short-acting together. Therefore, it has to be administered twice a day, and the action profile is also different, what we call as a shoulder effect. When you administer two mixed insulins at different time points, there is a shoulder effect which causes a hypoglycemia in the mid-time after injecting the insulins. Whereas if you can combine a flat profile of a basal insulin, with the short-acting insulin, then you can administer it as a truly once-a-day insulin, and that's what the second generation co-formulations offer us. We look at the insulin degludec aspart, which is a combination, which is otherwise called a co-formulation insulin, because these insulins are not actually mixed inside. That's the difference why we call this as a co-formulation. Mixed insulin means chemically they are mixed together, whereas in insulin degludec aspart, these are co-formulations where the basal insulin remains separate, the rapid-acting insulin remains separate within the cartridge. So here, the control with fasting, postprandial, obviously it's very easy to understand because it has got both the basal and the bolus component, both act together to control both the fasting and postprandial plasma glucose, and hence the HbA1c. Unsurprising that the quality of life is also better. Obviously, when the glycemia comes down, they start feeling better. It offers a flexibility in dosing compared to the other first-generation insulin. When we talk about initiating glargine U100, the typical dose is 10 units once a day, which is what is recommended. Then you up titrate. Glargine U300, the recommended doses, you start with 0.2 units per kg once a day. That means typically a 70 kilogram individual will require 14 units as a starting dose. And insulin degludec aspart is recommended to be started at 10 units with any major meal of the day, whichever meal of the day which has got a high carbohydrate which causes the highest glycemic excursion, that's when you're going to administer the degludec aspart. How do we administer? Initiate with 10 units with the most carbohydrate heavy meal of the day, then it can be increased to twice a day. Always, it's easy to convince the patients to take once a day insulin. Once they start getting used to it, then increasing to 2 times a day is much easier rather than convincing them to take twice a day insulin right from the beginning. So when we look at the meal, let's say the carbohydrate heavy meal is the dinner, then you administer the insulin degludec aspart at the dinner time, or if it's lunch, then it is getting administered at the lunch time. Again, this differs from individual to individual. We have seen that in many office-going individuals, they may have a very fast and quick breakfast, a packed small amount of lunch. When they come home, they are very hungry, they tend to have a heavier dinner. So for that individual, this could be administered at the dinner time. For another individual at home who is taking the heavier lunch, it could be administered at lunch. And intensification is depending on the glycemic excursions. And when the glycemic excursions are higher, you start increasing. When the requirement goes high, more than 40 units, you may consider taking it as twice a day. So one might think, being a basal insulin, how do we administer lunchtime and dinner time? But as I said, the elimination half-life allows you to be using this as twice a day or thrice a day also. In special situations, it's been proven to be useful in elderly, people with renal impairment, hepatic impairment, and adults with type 1 diabetes. Not a surprise, most of the insulins are useful. There is no real contraindications in situations like renal and hepatic impairment. It's only the dose that differs when you are using insulins in such situations. So a patient-centric insulin, insulin degludec being an ideal choice, which has got a better efficacy and safety, good quality of life, and a flexibility in administration. So degludec, to summarize, gives a flexible dosing pattern, truly has got a peakless action with flat and predictable profile, basal coverage which goes beyond 24 hours, and a better safety profile. Degludec offers the mealtime flexibility which can be administered at any time, any breakfast or lunch, and a simpler insulin regime with a better control in terms of both the postprandial as well as the fasting cholesterol control. Thank you.
Sir, thank you for the wonderful presentation, sir. You highlighted the importance of the newer insulins in improving the quality of patients. You also said about insulin co-formulation. You also mentioned about the total control. But still, it may not be affordable for many populations. So, at what point of time when you are using other long-acting insulins, you switch over to basal bolus type of insulin? What level you think the basal may not work now?
Sure.
So, how do you approach that?
A very good question. It's not affordable for every single individual. That's why when I started, I said it's not a dictum that every single individual should be on the best insulin. It doesn't matter. 200 rupees insulin might be doing a wonderful job for a type 1 diabetes. You don't really have to switch over to a basal newer analog as such. I mean, there are many individuals with type 1 diabetes in our government setting who are on a NPH and a short-acting insulin, which taken BD has been giving a good control without causing hypoglycemia. Fair enough, they can continue to use it. Glargine U100, let's say a type 1 diabetes on Glargine U100, there is no tail end effect, lasting entire 24 hours profile. It is giving a good control without causing hypoglycemia. Definitely we don't have to switch over. When the hyperglycemia is not coming under control, when there is a significant tail end effect where you need to use the Glargine U100 twice a day, which gives an uncomfortable situation where they need to take twice a day injections, or when the insulin requirement is very high. In these three situations, switching over to a second generation basal insulin analog will be helpful. A, because it lessens the number of pricks. B, we all see that when we switch over from a first generation to a second generation insulin, the total insulin requirement also comes down. So in these three situations, the second generation insulin analogs will be beneficial.
Thank you, sir. Any?
Thank you for the lecture, sir. When using this co-formulation, sir, how we have to calculate the dose? For some people, the basal, they will be comfortable, but when coming to the postprandial surge, they may need a higher dose. So while going for this fixed dose combination, people may need to inject twice, then this basal insulin level will go up. How to calculate that, or how to combine with these two insulin to tailor to that particular patient?
Sure. This is always a limitation for any mixed insulins, whether it's a co-formulation insulin or let's say the typical insulins, human insulins, analog insulin that we use as a 30-70 mix or a 50-50 mix. And this is our experience with most of the physicians also agree that in an Indian setting where there is too much of carbohydrate intake, the 50-50 mix probably works better compared to a 30-70 mix in many individuals. Therefore, you can change the rapid acting versus the basal doses in this particular individual. Whereas with the co-formulations at present, it contains a 30-70 mix, 30 of rapid acting and 70 of the basal insulins. Therefore, if it is not coming under control, you can increase the dose of insulin that you're using for that particular meal. If you're wanting to use it twice a day, that is also fine. But one fear should not be there. Using it twice a day, it will not cause hypoglycemia just because the basal insulin dose is going up. As I said, the elimination half-life will take care of it.
Any questions?
That was nice, Dr. Narayanan, giving in today's real world scenario, degludec is the ideal basal insulin, which if affordable, definitely should be offered to any type 2 diabetic patient who requires supplementation of basal insulin. And you also elucidated on how to progress it with ideg-aspart, that is somebody not having postprandial control, addition. Usually, see, sometimes practicality differs from science. We say if you want to put bolus, you got to put 3 times bolus. That's not the case in type 2 diabetes because there is endogenous insulin. You cover, initially I was because hardcore elements always with we had a skeptical view whether controlling one prandial will give smooth control over the entire day. But to our surprise, then we got to know from our own patients that when one major meal is covered with short-acting combination, aspart put along with peptide, the whole day becomes smoother. So sometimes I used to say, practicality should overtake this. Thank you.
Thank you, sir. That's why it's art rather than a science more often.
Yeah, that's why I always medicine has been defined by our Hippocrates. Medicine is both an art and science. Time is fleeting, and decision has to be made in seconds. Yes. If there are no questions, then we end up.
I would like Dr. Narayanan sir to felicitate our speaker. Thank you. That was an awesome presentation.